Our next speaker is Dr. Aman Kumar to talk on limited versus conventional internal limiting membrane peeling in macular hole surgery, the structural and functional outcome comparisons. I would request Dr. Lalit Verma to comment on it.
Thank you, ma'am. A very good morning to everyone. So the title of my thesis was Limited versus Conventional Internal Limiting Membrane Peeling in Macular Hole Surgery, a Structural and Functional Outcome Comparison. So we have no financial disclosure or proprietary interest. The purpose of our thesis was to analyze the structural and functional outcomes in patients with full thickness macular hole surgery using two different techniques of BBG-assisted ILM peeling, that is conventional in one group, and limited, that is sparing ILM over the papillomacular bundle in the second group. The standard treatment nowadays for an idiopathic full thickness macular hole is a pars plana vitrectomy, which is generally done to remove the anteroposterior traction as described by gas, and ILM peeling, which reduces the tangential traction and also helps in glial cell proliferation and hence leading to better macular hole closure rates and subsequent vision gain. So ILM is conventionally peeled 360 degrees around the fovea after staining with a ILM specific dye. The papillomacular bundle is a bundle of nerve fiber that carries the thickest nerve fibers from the fovea to the disc. So sparing, we had a hypothesis that sparing ILM over the papillomacular bundle would cause lesser damage to this area, and hence the inner retinal layers present in this crucial zone. So the deficit in literature was about the effect of tissue damage individually by the dye used and the ILM peel done in the papillomacular bundle area. So the study duration was 1 year. It was a prospective randomized interventional study. There were two groups of 15 patients each of idiopathic full thickness macular hole, and the inclusion criteria had phakic or pseudophakic patients with clear lens with stage 3 or stage 4 idiopathic full thickness macular hole according to the GAS classification of size less than 400 microns. So this is the flowchart of the study designs in which we randomized using random generated numbers using computer generated random number tables in two groups, and in 15 patients in the group A underwent total ILM peeling 360 degree around the fovea. And for the structural assessment, we went ahead with swept source OCT. And for the functional assessment, we got a multifocal ERG done, a ganglion cell analysis, the retinal nerve fiber layer thickness, and a central macular thickness. And this was repeated 3 months follow-up after the surgery. This was done in both groups. So these are the standard maps which were used. This is the central macular thickness in which the ETDRS grid was used of 136 millimeter, and the central macular thickness was calculated. This is the retinal nerve fiber layer in which superior, nasal, inferior, and temporal quadrants were measured. And this is the ganglion cell analysis in which 6 zones were there and individually compared in both the groups. And this is the multifocal ERG analysis in which we got these 4 zones around the foveal area. So just coming to the anatomy, this is the papillomacular bundle going from the fovea to the disc. So this is the standard group in which generally a 360 degree ILM peeling is done. This is one of our patients. And this is the group 2 in which only a temporal ILM peeling was done and the nasal papillomacular bundle area was spared. This is one of the representative images of a pre-op and a post-op image showing type 1 closure. And so I just wanted to say that in both the groups, we had a 100% closure rate, thus signifying that both in the hole size less than 400 microns with an ILM peeling either 360 degree or PMB sparing, there was the closure rate was same, and the BCVI was also significant gain in both the groups. There were we had 60% females in our group with a mean age of 65. There was no change in any choroidal thickness in both groups using, we measured it subjectively with a swept source OCT. The nasal and temporal hemifield ERG retinal response densities increased significantly in both the groups, thus suggesting the macular hole closure rates leads to improved retinal function. And this is due to the realignment of the inner layers, the bipolar cells and the molar cell configuration. And there's a decrease in the central macular thickness in both the groups, and smallest reduction was seen in the nasal hemifield, in which the PMB was spared. So RNFL, which was measured, only significantly reduced in the temporal quadrant of group 1 patients, thus concluding that the ILM peeling and not the BBG dye is the cause of the RNFL thickness loss. Also, we showed that there is a lesser ganglion cell thickness which is damaged in the non-ILM peeled region. So just to summarize, the limitations of our study was a smaller sample size and a shorter follow-up duration. And these functional changes could change over a longer post-operative follow-up. And ILM peeling does cause a significant structural damage, but the epidemiology closure rates and the BCVA gains were similar to the studies in the past. Thank you.
You can stop sharing, Dr. Lalit.
Wonderful contribution, Aman, to the literature. But this was expected, I think. There has been a lot of studies done that BBG is non-toxic. There are a lot of studies independently done for BBG that BBG is not toxic. So only thing which could have made a difference was the extent of ILM peel. But I would actually do this study in a larger hole, because less than 400 micron, honestly speaking, is hardly a hole in our setup, because we hardly get in practice 400 micron. We get 600, 1000, 2000 that type of holes. And in larger holes, the things have shifted to flap rather than to peel. And my question would be, suppose you have a, based on this, does the patient, did you do contrast sensitivity by any chance apart from these tests?
No, sir, we didn't do contrast sensitivity for functional analysis. We only did RNFL and GC and ERG.
Because these are theoretical tests which you make the patient aware. But by and large, does the patient in two groups, complain differently, because you had a phenomenal success rate of 100% both the groups. So did the patient have any subjective this thing by Dr. Saab, isme acha nahi hai, isme zyada acha hai, or whatever?
No, sir. So structurally and by the patient's symptoms also, it was no significant difference in both the groups.
And the second question was, based on your results, suppose you have to do a macular surgery in my eye, will you 300 micron hole? You will do only temporal or you will do complete?
Sir, if the hole size is less than 400 microns, then ILM peeling in the temporal quadrant also showed similar results, like 360 compared to 360 degrees. So I'll go ahead with only temporal peeling, sir.
So that means in less than hole, you advocate that nasal should not, papular macular bundle should not be touched at all.
Yes, sir, because it does cause damage to the inner retinal layers.
Okay. Good contribution.
Lalit, can I just Chitra one or two?
Just one, yes.
Lalit, actually, he said less than 400 microns, but he said stage 3 and stage 4 hole.
Yeah.
So stage 3 and stage 4 is larger than 400 micron. So that is a contradictory statement you have made. Okay. Number 2 is, in very small holes, even without ILM peeling, it may close. I mean, basically less than, very small macular holes. But interesting observation. I mean, it's a very interesting observation from the point of view of the temporal this thing. But you have made a mistake. On one side, less than 400. On the other side, you have written your patients were stage 3 and stage 4.
Yeah,
that was
group,
just the
group should be consistently similar. The variable should be only one. If you include stage 3 also, 4 also, and if you say whole size less than 400 could mean anything. Starting from 100 to 200 to 300, then you have to do subgroup analysis. That between 200 to 300, this was the issue. Between 300 to 400, this was the issue. Because if you say less than 400, this can cover anything from 100 to 400.
Yes.
And also stage 3, 4 should be analyzed separately.
Yes.